This trial is the KEYNOTE-006 trial, which is a phase 3 trial of Pembrolizumab versus Ipilimumab. And we saw the final analysis of that trial at ECCO last year, and we saw that Pembrolizumab indeed improves the response, the overall survival, and the progression-free survival over Ipilimumab, 2 immune therapies. So that's done. Now what we're doing is looking at various different subgroups to see if we can learn more about treatments for patients. So in fact, in the Spotlight and in another talk I gave, there were 2 things we did. In the Spotlight, we said, okay, for all those patients who had Pembrolizumab but progressed and then got Ipilimumab, how well did they do on Ipilimumab? And we found that they did just as well as patients who get Ipilimumab first line. So a patient can have Pembrolizumab. If they progress later, they may respond, progress later, or progress on Pembrolizumab, and you give them Ipilimumab, their chance of responding to that is exactly the same as whether they'd had that first line. This is really important. What it suggests is, and by the way, 13% of patients who'd progressed on Pembrolizumab responded to Ipilimumab, which is exactly the response you see first line. So what that suggests is that there's not cross-resistance. So if you're resistant to one immune therapy, you may not be resistant to another. So that's a really important message when you're talking to your patients and you're a physician and they may have progressed on an anti-PD-1 therapy. It doesn't mean, it's not a harbinger that they're not going to respond to Ipilimumab immunotherapy. They have just as much chance as if you'd given it first line. So that's the message there. The second talk I gave from the same study was then looking at all the patients in the study by their baseline serum LDH. LDH is a well-known prognostic factor in melanoma. We know patients who have a high LDH with stage 4 melanoma tend to do poorly. They have a shorter overall survival, and they have worse clinical outcomes with Ipilimumab and with BRAF and MEK inhibitors. And what we did is we found that this was true for Pembrolizumab in the KEYNOTE-006 study, that those who had a normal LDH at baseline did the best. They had the best progression-free survival and best response. If you had an elevated LDH, which was mildly elevated, 1 to 2 times the upper limit of normal, you could still respond. 34% of patients responded and had a good progression-free survival, but it was slightly lower than those who had a normal LDH. And if you had a very high LDH, your chance of responding was even slightly lower again. We also knew or found that in each of those LDH categories that Pembrolizumab was better than Ipilimumab. So if you had a normal LDH and got Pembro, you did better than someone who had a normal LDH and got Ipi. If you had a mildly elevated LDH, you did better on Pembro than Ipi. And if you had a significantly elevated LDH, and that was a very small subgroup, they tended to do better on Pembro than Ipi, although the numbers in that category were quite small.